Thank the organizing committee, Giovanna, Lisa, Lindsay, for having me here today to talk about managing symptoms of carcinoid syndrome and more. So the hallmark symptoms of carcinoid syndrome include flushing and diarrhea. The flushing is usually seen as redness that comes over the face. It might last a few seconds, maybe even longer. It tends to be dry, unlike other types of flushing. The diarrhea tends to be voluminous, quite often, a lot of times a day, interfering with the quality of life. And I wish it was just so simple that every patient would come to the clinic with both flushing and diarrhea. We treat them with medications and case closed, but unfortunately, it's more complicated than that. So carcinoid syndrome is actually a rare disease within a rare disease. It affects about 10 to 20% of patients with carcinoid tumors at any site. Misdiagnosis is very common, and correct diagnosis unfortunately delayed. And I'm sure many people here today can talk about their stories. What's interesting and important to know is that the syndrome, although you can't really measure it on a scan, is very important to the quality of life of patients. They've been telling us that for years, and I think we're finally starting to catch up. So what does it mean to be an orphan disease? Well, neuroendocrine tumors, there are about 100,000 patients a year who have neuroendocrine tumors. Of those, about 2/3 have GI neuroendocrine tumors. And within that group of GI neuroendocrine tumors, about 13,000 patients have carcinoid syndrome. In this nice paper looking at Medicare diagnosis codes, we see over a certain period of time, a 10-year period of time, that the diagnosis of carcinoid syndrome is actually increasing along with the diagnosis of neuroendocrine tumors. And the proportion of patients being given the diagnosis of carcinoid syndrome has gone from about 11% to 20%. I don't think the problem might be growing as much as our recognition of the problem is growing. To try to make this as simple as possible, the symptoms from carcinoid syndrome are driven by the release of serotonin and other neuropeptides from the actual tumor. So within the tumor, tryptophan is metabolized to serotonin. The serotonin is secreted into the bloodstream, and that nasty serotonin was what's going around and causing the flushing, diarrhea, and many other symptoms we'll talk about today. One of the huge problems, and something that's very upsetting to providers and patients, is the delay in diagnosis. I mean, I've met a lot of internists who, when their patient is finally diagnosed with carcinoid syndrome, they feel awful because they love their patients, they care for them as well as they can, but it's a difficult disease to diagnose. The symptoms are often mistaken for irritable bowel syndrome. Some of the symptoms are kind of similar. And the median latency, the amount of time it takes to make the diagnosis, is a whopping 9 years. I mean, it's just unbelievable. Almost a decade. So what are the most frequent symptoms with carcinoid syndrome? I'm going to start from the bottom. So number one is flushing. We talked about that. Diarrhea. Heart lesions is very important, and it's very concerning to me because you can have patients who don't have a lot of symptoms of flushing or diarrhea, or they don't even notice it. I've had patients say, they're flushing in the clinic, and I'm like, you notice you're flushing? They're like, oh, I don't really notice that too much. If they have spouses, it usually helps to figure out what's going on. And then, you might miss that they do have carcinoid syndrome and the heart is not being evaluated. So heart is very important to get your echocardiograms. You can have cramping, you can have swelling, wheezing, and lung symptoms, but niacin deficiency, not too common, aches and pains. But and not to forget, there are a lot of other types of functional neuroendocrine tumors, meaning there are syndromes that's not just carcinoid. Pancreatic neuroendocrine tumors are often associated with the syndrome. There's Zollinger-Ellison syndrome, insulinomas, glucagonomas, VIPomas, somatostatinomas. So patients with pancreatic neuroendocrine tumors should have a battery of hormones tested to make sure that they don't have one of these syndromes. And I didn't want to leave them out today. But a lot of the principles of management are the same. Now, if you can't tell, I put this slide together. It's 3 circles. But this is my conception of disease in general and carcinoid syndrome specifically. You have carcinoid syndrome is what you read about in a book somewhere. And that's what you read about, what we just showed you, the slides. Then there's actual patient experience, which is not 100% what you read about in a textbook, right? It's never exactly the same. And then you have the physician interpretation of both the textbook and the patient, which is also different. So there are lots of gaps and things that can be missed. So communication is key in a syndrome like carcinoid. You really have to talk to your physician. And what that means is talking about things that you might not normally talk about. For example, diarrhea. And I know you didn't expect me to talk about that today, but it's something that we talk about a lot in the clinic. And how does a clinician supposed to know what is going on with you if you have a symptom like diarrhea? Because there could be many causes. There could be short bowel syndrome. There could be bacterial overgrowth. You could have carcinoid syndrome, which very likely in this scenario. You could have pancreatic insufficiency, which could be from a pancreatic surgery or actually from the somatostatin analog shots. And you could have bile salt malabsorption. But there's no way to distinguish these. There are a few tests that you can do here and there, but really the best way to distinguish them is to have a long, uncomfortable conversation with your physician. Another symptom that I think is often not really addressed are the psychiatric and cognitive effects of carcinoid syndrome. And it's something that we don't really talk about. But in the clinic, it's actually quite noticeable. You'll have conversations with caregivers, with patients and their caregivers. You'll talk about treatment plans, and then you'll notice that there's a little bit of difficulty processing the information. The caregiver might say, well, the memory is not as good as it used to be. There might be a little bit of disinterest doing normal activities. The diarrhea might be making a patient not wanting to go to the movies or go to restaurants. They might be sad. There's a lot going on. So when we take patients who have carcinoid syndrome and we do neuropsychologic testing, which I often order for my patients, there are actually quite a lot of significant deficits. And you can see here there's visual perceptual function problems, visual memory, attention and concentration issues, executive skills and function. And in my opinion, there's also other psychiatric issues as well that's probably attributable to the carcinoid syndrome and being a cancer patient in general. And some of the causes of this can be, encephalopathy from the tumor metastases, which means that, things are just not right in your body. You can have too much serotonin in your body. You can have the post-traumatic stress disorder from being told that you have a metastatic cancer in your body. Pain can be a real big issue here. And then, of course, the treatments. The treatments are not so easy, right? They're easy for the physician to prescribe, but not so easy for the patients to have to take. Now, why are these patient symptoms so important? Well, we're understanding more and more that quality of life is important to patients with cancer, and that if you actually approach the disease by not just treating the disease, but treating some of the symptoms, you can actually make patients feel better and do better. So some of my colleagues have put together a program to address some of these issues in patients with cancer, and they called it Growing Resiliency and Courage, or the GRACE program. And this class or course, it's not really a support group. It's more of an educational seminar that lasts about 6 weeks, and it's for patients who are diagnosed with cancer. But it's based on the teachings of Viktor Frankl, who was a physician and psychiatrist, who was actually in the concentration camp. And he took his experiences, he was a clinician from every day. So even when he was undergoing a lot of suffering and pain, he was observing what was going on to the people around him. And he found that the people in the camp, that some people were actually able to take away meaning and happiness from even a very horrible human condition. So some of those teachings are being transmitted into this program. And as you see here, it's a 6-week course, different topics each week. It's about 2 hours. There's a couple of clinicians, and there's a round table of patients. And as you can see, they probably get pretty close over this period of time. What's really fascinating is that when you look at how they feel before and after such a program or addressing these types of concerns, you see that patients do a lot better. They have improved spiritual and psychological adjustment, and they seem less hopeless, they're happier. So it actually amazingly works. So, and the reason why I show that is that treating the symptoms of cancer is not something to be ignored. It's something that we should really address. So with that, let's talk about neuroendocrine tumors and functional syndromes. So there are a two-pronged approach. One is actually tumor management, and the other is syndromic management. Oftentimes, they're the same. Sometimes they're separate. So that's the kind of boxes that we should be thinking about. Now, the mainstay of treatment for carcinoid and neuroendocrine tumors is somatostatin analog therapy. They've been used for decades to control the symptoms of carcinoid syndrome. They can also help with functional pancreatic tumors and other atypical syndromes. We're fortunate to have many types. There's sandostatin, there's lanreotide. These also, fortunately, control tumor growth. I love this paper. I mean, 30 years ago, a series of patients was treated with octreotide 3 times a day, self-administered, patients with carcinoid syndrome, and 22 out of 25 had improvement. I mean, I've never been in a study or a protocol where that high rate of success. I mean, almost everyone got better. 72% had improvement in their urine 5-HIAA, and this treatment effect lasted for about a year, or the improvement lasted for more than a year. And similarly, data has been shown for other types of somatostatin analog therapies. So every study that we do that we use as somatostatin analog therapy, for example, this one with lanreotide, patients do better. So until recently, that was the majority of what we're doing, but our understanding of syndrome control and tumor control are evolving. So if you have a recurrent carcinoid syndrome and you've progressed on somatostatin analog therapy, you have a lot of options. You can control the tumor by doing liver-directed therapy. You can do surgical cytoreductive surgery, like my esteemed colleagues have already talked about today. You can do peptide receptor radiotherapy, which we'll talk about later today. And if you just want to focus on syndrome control, your options are now to use a new approved medication, telocrostat ethyl, or Xarelmo, which is a tryptophan hydroxylase inhibitor, or you can increase the dose of the somatostatin analog or the frequency. So let's talk about telocrostat ethyl. It's a peripheral acting serotonin synthesis inhibitor. It's an oral delivered inhibitor of tryptophan hydroxylase. It's a pill. You take it. It improves it blocks the metabolism into serotonin and improves carcinoid diarrhea. So here in this phase 3 clinical trial, we see that using telocrostat ethyl or Xarelmo in differing doses significantly improved the diarrhea associated with carcinoid syndrome. Now, this improvement in diarrhea is a bigger deal than one would initially think. I mean, someone says, okay, your diarrhea is a little bit better, but so what? But you know, improving diarrhea, improving these symptoms really does improve quality of life. Another interesting fact is that, you know, patients who have diarrhea and improved and the serotonin modulated, they actually gained weight. So one of the things I like to do research on is weight gain in cancer patients, and it's very difficult. It's very difficult to find a medicine or a treatment that helps gain weight like this medication was able to do in these patients. And you know, I'll just touch on peptide receptor radiotherapy today because this is also a very effective treatment for carcinoid syndrome. As you see here from the results from the NETTER-1 phase 3 trial, diarrhea was improved in patients who received peptide receptor radiotherapy versus the increased dose of LAR. Also, that also correlated with improved global health and quality of life. So to summarize, carcinoid syndrome can lead to significant side effects. We need to focus on controlling both the syndrome and the tumor. Please make sure if you have carcinoid or maybe have carcinoid that you're getting your heart function, your heart valves checked, your right-sided valves every couple of years. Somatostatin analog therapy is the backbone of medical treatment. We have a recently approved medication that can also help carcinoid diarrhea, and that PRRT can also improve these symptoms. Thank you very much for your attention today.